Good afternoon, ladies and gentlemen. So welcome to the Advocacy and Development of Emergency Medicine second session. So we are going to have several talks today by experts globally, and a big diverse community is here, and this session represents that diversity, I believe. So let me introduce the first speaker, and also let me introduce you myself. I am Dr. Kaushila Thilakasiri. I'm an emergency physician from Sri Lanka, and I'm also the General Secretary for the Sri Lanka College of Emergency Physicians. So the first speaker today is going to talk to us on a very interesting topic from Greece, the supra-specialty training program in emergency medicine. Please welcome Dr. Dimitrios Tsiftsis. He's a surgeon by training, but he's an emergency physician now of all kinds, and he's also been the immediate past president of the Society of Emergency Medicine in Greece. Welcome.
Thank you very much for the introduction. Okay, thank you very much for this introduction, and thank you for the opportunity to be able to present our experience after having almost 10 years now worked with the supra-specialty. So this is the timeline in how the Greek program has advanced to where it is today. But before I go into details, I'd like to pay tribute to the people who actually brought the essence and the notions of emergency medicine in Greece. And this is Professor Askitopoulou. She was a professor of anesthesia in the University School of Crete back when I was a student there, and she's the first one that started mentioning and teaching in 1992 the notion of emergency medicine when it was nothing back then. So back to the timeline. Since 1998, we have started developing emergency departments in Greece. Only in 2005, we started believing that we should have dedicated personnel working in the emergency departments. But like everything else in Greece, this happened very slowly. The first ones, including myself, were appointed in 2014. In 2019, we created the supra-specialty for emergency medicine, which is a 2-year training program after one of the primary specialties. And just in 2021, we created the training program for nurses in emergency nursing, and now they have all sorts of rights in the field of emergency nursing. So emergency medical services in Greece are provided in emergency departments, which are always in hospitals. And in the beginning, as I told you, they were designed to be run by physicians from different medical specialties already appointed in other floors of the hospital, and they could come down in a rotating fashion and cover emergency cases of their respective specialty. Now, this led to another problem. Since human resources were not adequate for a clinical department to provide both inpatient and outpatient care, while full-time engaged in the emergency department, simultaneously we created a rotating system in which every 2 or 3 or 4 days the emergency department would be open in a different hospital in a rotating fashion so as to preserve this kind of manpower. So we have some unique features in our system. So first of all, emergency departments are not open every day. In metropolitan areas, we work 24 hours, then we're closed for 3 days, and then we're open again. In more urban areas, this is 1 every 2, and in more rural areas, emergency departments are open 24/7. We have a supra-specialty training program, which is 2-year training after 5 or 6 formal training in one of the primary specialties. And still, emergency departments are mostly staffed by physicians from hospital departments. And of course, EMS and emergency departments are not linked. So we did a survey in 2024, the Hellenic Society for Emergency Medicine did that. We have available about 580 positions in 52 emergency departments in Greece. These are the openings that exist. Everything is run by the Ministry of Health. From these, 295 physicians have been appointed in these 520 places, so about 50% of the positions are covered. But this is very unequal because most metropolitan area emergency departments and urban are full, while at the same time others that are more rural remain empty. And from these 300 physicians, almost 100 have been certified in emergency medicine. So, does this model work? So we did, first of all, we did an economic survey to see if the system that we had with physicians working from the floors covering their respective emergencies would be more cost effective than having an emergency medicine supra-specialty. Now it goes without saying, due to the idle time that specialties have, that it's a lot cheaper to have emergency medicine. So you see that in this model we would need a lot fewer physicians if we were all trained in emergency medicine. Now this makes perfect sense if you keep in mind that we would have, let's say, a dermatologist, and we would pay him to be 24 hours in the emergency department, and he would see only acute dermatological cases. How many are those? Let's say 40, 50. While if it was an emergency physician, he would be able to see about 3 to 5 patients per hour. So this idle time is what actually increases our cost, and this is why we would need fewer manpower if we were all trained in emergency medicine. Then we did another survey in 25. Now keep in mind we already have people appointed there. Some of them are trained in emergency medicine, to see how good they feel and how comfortable they feel taking care of different cases. As you see from the graph, we do not feel very comfortable taking care of children. But as with the rest of the cases, like major trauma or resuscitation or critical care patients, we feel pretty comfortable taking care of them. And this questionnaire was done all over. Now, if you do a subgroup analysis of this, and we only focus on those doctors working in the emergency departments that have been certified in emergency medicine, then almost everybody feels at least comfortable in taking care of everything besides children. And of course, since we have dedicated children's hospital and our work volume is very low, then it makes sense to understand this. But it's a different thing feeling comfortable in doing it and being effective in doing it. So we did another survey, and we divided, we took our non-trauma section of the emergency department, and we shadowed 2 different categories of doctors working there. So for the first part, we had doctors, as usual, from internal medicine that would do the rotation there and would take care of tier 3 and 4 patients with non-trauma. And for the same number of shifts, the same hours, we had people, internal medicine specialists, but worked in the emergency department for more than 4 or 5 years, who do the exact same job. Now, if you see, these groups are perfectly matched, but the results are amazing, because although they are both internal medicine from the primary specialty, in all metrics, doctors working in the emergency department did better. They moved the patients faster, they had less waiting times, less people waiting, without changing the number of actual admissions and without having more people that were discharged in 24 hours. So all over the board, even if they work with their primary specialty, the training they get in the emergency department makes them more effective than their floor counterparts. And this is the path to being an emergency physician in Greece. So it's 5 or 6 years of formal residency training, during which 2 or 6 months are exclusively done in the emergency department. And then you do 3 to 6 shifts per month in the emergency department. And of course, some of them, after they finish the primary specialty, they become board certified in ICU, and they are favorable for being employed in the emergency department. So a total training to be eligible to sit for the emergency medicine board exams in Greece would take something between 8 and 13 years of training or on-job experience. So now I've had 8 years of experience with the supra-specialty, and I truly believe there are some merits that need to be addressed. So before you burn me, hear me out. So I went and asked ChatGPT and the literature, why should ICU be a supra-specialty? Now, you can't see all this, but whatever they say has direct application in emergency medicine. It should be because it's high complex and there's a lot of pressure and it's multidisciplinary nature and they need to learn on job. Okay, if it's good for the ICU, then it can't be that bad for us. But still, even in countries where emergency medicine is a primary specialty and it has been very developed, still there is a constant need for consultations. 24 to 5% to 54% of patients entering an emergency department, which is run by emergency medicine specialists, will need a consultation. Now, these consultants are not in the department. They are either on the floor or they are at home to give a consult. And this will lead to a 55% increase in length of stay in the emergency department. So, staffing ORDs with double certified physicians ensures departments have specialists on the floor who bring domain-specific expertise while at the same time understanding the core principles of EM. And I say again, this has to do with double certified physicians. Now, this model promotes continuous interdepartmental learning, facilitates ready access to expert advice, enhances communication. Have you tried speaking orthopedic? Or if you speak orthopedic fluently, then how do you speak rheumatology fluently? It will be much easier if you have a rheumatologist working with you and he can communicate with his counterparts. Everything will be much easier. So having double certified doctors makes administrationally perfect sense. Because what do we need in the emergency department? We need people to flow fastly. So now I have experts on hand, flow continues, flow doesn't stop. Training-wise, you continuously learn from the expert you have next to you. Of course, you know your core emergency medicine, but instead of asking for a cardiologist for a consult, you ask your colleague, he's there. And of course, you get expert delivery of care for each and every patient. And I think all these three things is what make a good emergency department. Now, let's go into physicians' well-being. We have discussed a lot of it in many sections here on well-being. Emergency department physicians are their most burnout. And this goes without saying. They lead a miserable life because of burnout, but the good thing is that we die younger than other specialties. So we won't have to endure this pain of burnout for many years. But what does burnout actually do? It's a nice word. What happens? Now, emergency physicians, they are high-tier professionals. They are very selfish. They will not go for help. So they will turn to substance abuse, depression, suicidal thoughts. Early retirement. Emergency medicine has the highest rate of mid-career dropout. And even if they don't quit, they slack. You start seeing fewer patients, you don't get satisfaction, you start working more slow. So all these things have to do with burnout. And when you see all this, then of course younger people will not come and enter the residency program. So what we have created, the system has created a live fast, die young situation for emergency physicians. And we are creating something from a career, we're changing it to a pit stop. Now we have learned, again here, we have talked a lot about it, that burnout doesn't have to do with people. It's not the weaklings that get burnout, it's the system that's the problem. So if it's a system problem, let's see how we can change the system to have better well-being for our doctors. So first of all, you need to see what you can change and what you can't. And in Greece, we can't get more emergency physicians. We can't hire more doctors. We can't hire more nurses. We can't decrease the number of incomings. Actually, they are increasing, and we're a victim of our own success. We cannot decrease the noise and tension in the emergency department, and definitely, because we're talking about Greece, we can't increase salaries. But what can we do? We can find a way to decrease workload, to increase physician control of shifts, to increase self-value, to increase diversity. So, in emergency department work, which is very stressful and demanding, double certified physicians can mitigate this burden by maintaining clinical hours in their primary specialty, reducing daily emergency department workload. And again, if the time comes, they can always retire with their primary specialty, because now you have something to do. If you're an emergency physician taking care only of tier 1 patients, we can only work in an emergency department taking care of tier 1 patients. So now we can diversify by doing shifts in our primary specialty in the emergency department, or we can work outpatient hours, or half and half, outpatient and emergency department, or you can take some time off, go to a primary care office and practice your primary specialty. There's of course continuous professional development through on-the-job training, and of course you have less stress because you know that if worse comes to worse, I have the safety net of my primary specialty to fall on. So, what benefits emergency physicians have? They have flexibility, which makes emergency medicine more attractive. So at the end of the day, our model has well-trained ED physicians, constant on-the-job training, better ED flow, expert consultation on the floor, a healthier workforce which leads to retained workforce, which leads to experienced workforce. You need the old doctors. They are experienced. They can move faster. We have a work-life balance, end of career options, and of course all these things make it attractive for young recruits. So what I'm saying is, let's study the potential benefits of emergency medicine, supra-specialty. There are still very few places that have the supra-specialty, and if there are merits, now is the time to see them. So if you are interested, this is my QR, scan it, and we can get together and see how much more we can learn, because even if you are a heretic, sometimes heretics are correct. Now, don't get me wrong. Don't get me wrong. I was the past president of the society, and the society's main goal is the creation and development of a residency program in emergency medicine in full harmonization with UMS. This is a policy statement of the society, and I am the one to have signed it. But at the same time, we are advocating that we keep the supra-specialty training program running in parallel with the formal residency program. And if all else fails, I'll go back to my island, work in primary care, and fix my work-life balance. Thank you very much.
Dr. Tsiftsis, that's a very interesting perspective, especially for someone who is coming from a country that has established emergency physician training as a main specialty. And I would like to ask the audience if you have any questions. We have 5 minutes for questions. Yeah. I was so told that I can throw this away. I'm going to try.
Okay. Could you hear me? Okay.
We can hear you very well.
Hi, my name is Marian. I'm from Germany, Munich. Beginning your lecture, you mentioned the emergency departments in the cities are not open 24/7. So I was like, I mean, I didn't know this only in Greece. So what are the doctors doing in the meantime, and why? I mean, why do you do it? I don't understand it.
This has been like that for ages, since 1980 something. I tried to explain why the emergencies were covered from the floors. It was impossible to do both elective and emergencies all along, so they created this rotating system. So now, during the days that the emergency departments are not open, we only take tier 1 cases from EMS. We're open for them, and we resuscitate whatever happens in the hospital, and we take a few walk-ins that randomly strolled around and just fell. We take care of them also, but we are not officially open.
But I mean, do you think it's good, or?
That's my next paper.
Okay.
I have a strong opinion on that also.
Okay. Oh, sorry. What did you say? Okay, who wants it?
Can you teaser, like the next paper? What's your strong opinion?
No, without data, it's just an opinion. Forget it.
Okay.
So let's stick to the supra-specialty in emergency medicine, which truly has merits, and I think we should further discuss that.
Thank you. We can take one more question. Yeah? This side of the audience. Okay, Dr. Tsiftsis, I think that was a very informative and a new perspective. Maybe like the Greek introduced democracy to the world, this might be the next game changer. We don't know. Thank you so much. I would like to invite the next speaker. Good afternoon, Dr. Huefner. Please have a seat. So the next speaker is Dr. Andreas Huefner. He's emergency department at Caritas Hospital, St. Joseph's. He's the head of the department. And he has dedicated much of his career to advancing emergency medicine, both clinically and academically. Originally trained in surgery, he transitioned to emergency medicine in 2008 and has since then become a strong advocate for the development of emergency medicine as an independent medical specialty in in Germany. I'm so sorry. We are really honored to have you today, speaking to the audience on the social media platform as well. Over to you, sir.
Thank you very much for this introduction. Ladies and gentlemen, dear colleagues and friends, I want to take you on a journey today, the long and winding path to an independent emergency medicine specialty in Germany. Imagine you present to an emergency department as a patient, and the gatekeeper at the reception desk decides whether you will be seen by an internist or a surgeon, but definitely not by an emergency physician. Until 10 to 15 years ago, this was still reality in Germany. And we even had physically separate emergency departments for internal medicine and surgery. And a triage system has only been mandatory since 2018 now. So the patient would have been evaluated by the assigned department. They did the diagnostics and the treatment. And if the first assignment was wrong, so the patient was not for this department, then he had to be transferred to the other department and they would do it all over again. So the result was fragmented responsibilities, variable waiting times, inconsistent quality of care, and frequent transfers between departments. And as I said, the first decision was not made by an emergency physician, but by the system. So why does EM as an independent specialty really matter? Emergency medicine is well established worldwide. There are more than 100 countries that have a recognized independent specialty. And Germany has a paradox. We have a strong pre-hospital system, which is that we have an EMS system like the Franco-German EMS model, where the physician is dispatched to the emergency and we basically bring our emergency room to the patient. But when the patient arrives in the emergency department, there is no emergency physician. And this debate goes on for a while now. And this has also implications for patient safety, training quality, workforce sustainability, and academic development. So what are the structural problems in German hospitals about emergency medicine? We have the patient in the center, but we have rotating residents, usually assigned temporarily, and so we have frequent team changes and handovers. Nobody truly owns the whole patient pathway, and the presence of the attending is very variable and depending on daytime. We also have variable training quality and limited research structure. So there's a variable emergency care standards, different approaches, variable quality and uncertain outcomes. One patient, many hands, but no clear owner. What are the milestones in the development of emergency medicine in Germany? There was a growing discussion, especially in academic hospitals since the early 2000s, that increased the awareness for the need of a dedicated specialty. And in 2008, the DGINA was founded, the German Society for Emergency Medicine, which built a professional home for emergency physicians and advancing education standards and advocacy. In the 2010s, more and more hospitals built centralized ED structures, which improved patient care and patient flow. And since 2018, we have the supra-specialty in clinical emergency medicine and acute care, and which is recognized German-wide. But this is only accessible for doctors who are board certified in another specialty, and it's an additional 2-year training. And usually the board training is 5 years in Germany, so it takes 7 years until you have this super-specialty, and this is not recognized like a training program in the US or anywhere else. So what are the key arguments for and against independent specialty? The pros are clear career structures for trainees, from trainee to specialist. A dedicated training pathway would be really a good idea. We need a consistent curriculum with skills and assessment. This would improve the patient safety with faster decisions and safer acute care, and it would be more attractive for young physicians if they would have a sustainable and appealing career pathway. And what are the cons? One major concern is that on the existing specialties, they fear of overlap, competition, and loss of roles. So they specifically fear that younger doctors would go into emergency medicine, for example, instead of internal medicine or anesthesiology. And we also have high political resistance within the medical chambers. We have very traditional structures and a lot of stakeholders with different interests. And also the financial implications are not making it much easier, because there is a question who will pay for the costs for implementation of a new specialty. But the goal is stronger professionals, safer patients, and better emergency care. And the challenge is not whether to improve emergency care, but how to shape recognition wisely and collaboratively. Let's have a look at the workforce and demographic pressures. Emergency medicine is under pressure all over the world, and we have a rising demand but a shrinking workforce. And we have increasing volumes of ED visits with high acuity, and this causes longer waiting times and crowding situations. The aging population with complex and chronic conditions also increases the demand on emergency care, and the clinicians, the number of clinicians and nurses especially as well, is more or less decreasing, which causes real problems in Germany too. And rotating residents have a high workload, and the frequent rotations, they cause fatigue, stress, and reduced well-being, ending in burnout sometimes. So we also need a career perspective in emergency medicine, clear pathways, mentorship, and growth opportunities are very important for retention and sustainable future for the young doctors. So we have more patients, we have fewer staff, and a great pressure on emergency care. What is the political landscape in Germany? In Germany we have a federal structure. We have a state medical association, so every federal state in Germany has a medical association, and there's even one state which has two. So altogether we have 17 medical state associations. And if you want to establish a new specialty, you have to propose this and submit it at the German Medical Association, which is the federal level institution. And there will start discussion and deliberation. So they will try to come to a conclusion. But in the end, there is a voting system, and every state medical association has one vote. And to get the majority, you would need 9 of the 17 votes to really succeed. And then the implementation would start gradually. So you see, the reform process in Germany is slow, and change is more evolutionary, not revolutionary. On this map you see the 4 remaining countries in Europe that don't have an independent specialty yet. It's the 3 German-speaking countries, Germany, Austria and Switzerland, and Greece. Last year somehow was a turning point. We started a campaign from the German Society for Emergency Medicine. It was called Emergency Medicine as an Independent Specialty Now. And it came with the implementation, not implementation, but the publication of a structured 5-year curriculum with more than 170 defined competencies. And the reception was quite well, especially with the young doctors. And a few weeks ago, even the German Medical Students Association endorsed the implementation of an independent specialty in EM. So what are the lessons learned and the conclusion? In Germany, the healthcare system changes slowly. And EM care depends on many specialties and professions, and the most important thing is collaboration. Unclear ownerships hinder. Quality depends on training. Better training means better decisions, better teamwork, better patient care and better outcomes. So in Germany we have an excellent pre-hospital EMS system, we have high medical standards, we have experienced clinicians and increasingly centralized EDs, but we are still lacking the dedicated specialty. Training remains fragmented and the career path within emergency medicine remains quite unclear. And the responsibility in the EDs also remain too dependent on local structures. So, but Germany does not need to start from zero really. The question is no longer whether Germany needs this, but when and how. And better structures create better professionals. Stronger professionals create better emergency care for everyone at any time in every ED. Thank you for your attention.
Thank you very much for that in-detailed explanation of the situation in Germany. We will move to the audience. If there's any questions, we can take about at least one question we can take. Yes. Please, could you pass the mic?
Okay, so where does it stand? Where are we at in this process? So you started this, proposed this last year, and people like it. So where are we at?
Yeah, the thing is that we as a society have to talk to a lot of politicians, right? As we said, you have to convince the state medical associations, and this is not easy because there are many stakeholders from different medical societies, and most of them don't want to give something away, and they think they lose something. And that's the main problem, in my opinion. So it's really hard work to convince them that it does make sense, and it will still take a while, but we are at it.
So when do you predict that this will happen?
I'm not sure. I will retire in 2030, so I probably won't really see this happen.
Last question is, how can we help?
You mean you in the US or?
In general, anyone.
In general.
Anyone.
Well, actually, what we would need is people who who go to their medical associations and promote this with us, the implementation of this new specialty. And we have to talk a lot with all the stakeholders, and we have to try to convince them. That's the only way right now in Germany.
I think there are lots of questions. Could we please pass the mic on? We can have 3 minutes more for the questions.
Please.
Thank you very much. That's really interesting. I'm just wondering, in your advocacy activities and the persuasion of your state ministers, who are your medical allies? In many cases, it's been orthopaedic surgeons or people who are involved in trauma care, the other specialists who are your greatest allies and friends. And I'm just wondering who you have in Germany, or are they all enemies?
We don't really have allies yet. Yeah. We have a chance that the general practitioners might work with us, which are a big group in Germany, and we're working on that. But I'm a surgeon myself, so I mean, they are not the major enemies. It's more internal medicine and anesthesiology. Yeah, I think that the surgeons can be convinced somehow.
Yes, Dr. Dimitrios.
Okay, so this is very fascinating. This, I thought, only we take a lot of time to change things. It's nice to see it's happening even in Germany. So the question is, until you get the formal training in emergency medicine residency, how can you provide better care in the meanwhile for your people? So what are you doing training-wise in this transition period?
Well, as I stated, we have the supra-specialty like you have, the 2-year training. There is also a curriculum for that, which is dependent on the hospital that does the training, how much the patient, the doctors can be exposed to cases that really keep them learning, and we have about 2,000, as far as I know, about 2,000 doctors who are trained with the supra-specialty yet. And that's actually not enough yet to really cover all the more than 1,000 emergency departments in Germany. And that's a big problem. So quality is a major problem still.
Thank you very much, Dr. Huefner. In the interest of time, I think we will not be able to take any more questions. We will need to move to the next speaker. Thank you so much.
Thank you.
Our next distinguished guest speaker is Dr. Abiola Fasina-Ayoola. She's an emergency physician and a health policy consultant based in Lagos, Nigeria. Dr. Fasina-Ayoola completed her training in emergency medicine at the Mount Sinai School of Medicine in New York. Her several years of practice, she then completed a 2-year fellowship in emergency medicine point-of-care ultrasound and master's in health policy research at the University of Pennsylvania, Philadelphia. Over to you, Dr. Fasina-Ayoola.
Okay, my slides coming up. Okay. All right, so today I'm going to be talking a little bit about our work in Nigeria developing emergency medicine. So we're going from Germany to Nigeria and talking through some of our own challenges with developing this specialty, which is still very relatively new for us. So the title is Scaling the Summit, Defining Progress and the Future of Emergency Medicine in Nigeria and the West Africa Sub-Region. I am medical director of Abiola. I run Econ, which is a consultancy in emergency and critical care, and I'm also a faculty chair in our national postgraduate college, hence all the logos. We do receive GE and Sonosite funding for some of our research and training. I'm also funded through the Duke Global Health Institute for Sepsis Research. I have no other financial declarations. These slides were made with the help of AI. I declare this. So in terms of my background, as Doctor has said, I trained at Mount Sinai in New York and then did a point of care ultrasound fellowship at the University of Pennsylvania. I'd always done global health. I was always going back and forth to Africa throughout this time working, and then had the opportunity to move back to Nigeria 7 years ago after spending about 19 years in the States. And at that time, I was coming into Nigeria at a time when a lot of advocacy and a lot of political pressure had come to a head. And there was now all of this energy around developing and accrediting a specialty in emergency medicine. And so initially I started as a foundational board member on our National Postgraduate Medical College faculty. The way it's organized in Nigeria is that this college is responsible for all postgraduate specialist training in the country. Every specialty has a faculty with a chair and some principal officers. And our initial one, obviously, was chaired by and was a board full of physicians who weren't EPs. In Nigeria right now, we have 4 emergency physicians who have been residency trained, of which I am one. And so our initial faculty board actually comprised of non-EP doctors. And then I was sort of the only one there serving as the emergency medicine voice. We also at the time started our Association of Emergency Medicine Healthcare Practitioners. We didn't have a professional organization in the country that served us as emergency physicians. And at the same time, I became medical director of Abiola. It's a 290-bed private hospital system in Lagos, and I was still working on Econ. So let me tell you a little bit about emergency medicine in Africa and the West Africa sub-region. We heard the keynote speaker today. A lot of things have been happening in emergency medicine in Africa. South Africa led the charge, and then Ghana from West Africa, Rwanda, Uganda. And then in West Africa, really after Ghana, there's really been nothing else in terms of formal training for emergency medicine in the region. But clearly we need it. Of all of the countries in Nigeria, in Africa, stats of our country, we're 230 million people strong and growing. Lagos, where I live, is 23 million people. Even though there's a lot of funding for malaria, HIV, TB, which are very important, road traffic accidents, stroke, intracranial hemorrhage, these are the things that are killing us now, diabetic complications. We're seeing a lot of this, and we are not really organized to do this. We have, as everyone else discusses, a very fragmented emergency healthcare system, a pre-hospital care system. Not all the states have them, and then the organization of that from the federal standpoint is very complicated. Just like a lot of places, Nigeria is federalistic, so every state does their own thing. So in terms of how we have been and where we are now, as I said, South Africa was the pioneer in the 1990s, and they produced the first trained EPs on the continent, and then East Africa subsequently followed. In West Africa, where we are, Ghana really was the only one that had any kind of formal pathway to emergency medicine training, and then Nigeria started in 2020 after we were recognized as a specialty in 2019. So a lot of other places try it in different ways. The Ghana way was to start with one place, put all their resources there, and then eventually accredit another center, so that now in Ghana there are 2 places where you can obtain training. That was not going to be a strategy that could work for Nigeria. First of all, we're population-wise more than 10 times the size of Ghana. And then Nigeria is also very politically fragmented. And we are now split into these 6 geopolitical zones. And so anything that you do has to be replicated in 6 places for equity. And so the way that we did this was that actually residency training programs were accredited across the country in all the geopolitical zones, and we have 10 of them now, 9 of which are active. The challenge, of course, is that, as I said, there are only 4 EPs. And so we have a lot of training programs now where we really need emergency physician support because they're actually being anchored by allied specialties, orthopedic surgeons, anesthetists, internal medicine doctors, and family medicine physicians. So we're really trying to figure out ways to sort of impart emergency medicine training with a lack of trained physicians. That's kind of where we are. For Nigeria, as I said, we were recognized in 2019. The faculty initially convened and recognized 30 fellows, 10 of whom are EPs, so 3 in country, 7 in the diaspora. And then we've had a few new batches come in. Our first residency started in 2022, and they're now in their 4th year of a six-year program. So we are expecting our first Nigerian EPs to graduate in 2028, and they will be our first batch of EM doctors. So the state of emergency medicine in our country, and by the way, there's quite a difference between the public and the private sector. What I'm describing is really our public sector. Post-independence, these massive, beautiful hospitals were built, 1,000, 2,000 beds strong, and now we're having aging infrastructure. They're inadequately resourced. We've been hit very hard by emigration. Last year in Nigeria, 20,000 specialists left the country to go away. So it's not just the fact that we're new with no specialists. Even in the specialties where they're well established, we find that we really just don't have people anymore to really staff and train. UCH Ibadan was the first one to start an EM residency, and now we have 9 approved sites. And it's an antiquated system, and it shows that there are no emergency physicians present because, like a lot of places when you start, you see, medical ER, surgical ER, O&G ER. Part of what we are even trying to convince our medical directors about is to coalesce this. Now that there is an emergency medicine specialty, we do not need to sort of waste resources duplicating things across 4 places. Why don't we pool everything and make one emergency department really good? So as I said, I was appointed faculty chair. This is our training organization for the country. What was so outstanding about the appointment was not that it was me, of course, but it was because it was the first time the chair was actually an emergency physician. Prior to this, our faculty was led by an orthopedic surgeon. And so this is the first set of principal officers where all 3 of us, the chair, the secretary, and the first Senate officer are all EPs. And so we've really come into a lot of work. We're doing a curriculum review. We're trying to establish subspecialties in disaster medicine and critical care, things that we need in the country, and also trying to come up with international collaborations to lend strength to our training. Now we have 75 registrars enrolled across the country in emergency programs across 9 sites. 8 of them have now passed their Part 1 exam after the first 3 years and are going into their senior residency. And we're continuing to accredit new sites, continuing to define the specialty. One of the things that we're getting as feedback from a lot of people who are training for us, the other specialties, is one, what are you guys? What do you do? There's still a lot of explanation of why do we need an emergency physician? What is the difference between you and the orthopedic surgeon? Isn't it just BLS and ACLS? We're still kind of having those conversations. And like a lot of places, we are arguing for turf. Anesthesia doesn't need to come down all the time. We don't need ortho all the time. We don't really need you guys all the time. Let us resuscitate, stabilize, and then we will call you when we need you. But we also have to be very diplomatic and clever about that, because it's not every program that has an EP. So at the same time that you are demarcating your space, you also don't want to turn people off and let them abandon you. And so it's this sort of balance that we're constantly trying to balance and meet. So currently, as I said, the things we're doing, our second curriculum review is underway right now. We're working on that. There were questions about what to do on off-service rotations. We had people going to internal medicine rotations who were going to clinic. Absolutely useless for an EP doctor. We need to explain to our colleagues what our EM doctors should be doing when they go to an off-service rotation. We do not need the ER doctor who's on rotation in internal medicine to be seeing like your clinic patients for the entire 6 months. Certainly they should help you with your work, but they should be learning about ED consults. In orthopedics, they should be learning about fracture reductions and when to call ortho. So these are some of the things that we've had to clarify on this go-round. And then we're also trying to integrate new technology, POCUS, toxicology, disaster medicine, and think also about our resource limitations, because one of the big things for me that was an issue when I moved back to Nigeria 7 years ago was really realizing that my training in the States, while very technically sound, didn't prepare me for practice in the resource-limited settings. My scores, my prognostications, my expectations for imaging and labs cannot be met in this environment. So how do we teach emergency medicine in this place? And then diploma courses, because we have a huge cohort of people who've been working in the ER all this time, and we need to give them a path to recognition. Many of them are not interested in residency program, but they are our workforce, and we have to find a way to standardize the knowledge that they bring to the department and also appreciate them for what they're doing. So we're considering diploma courses that we can give to folks like that. I think one of the most exciting developments for us in our region is that the West African College of Physicians is about to also come on board. So in West Africa, there are two colleges. Nigeria has its own college, the National College, that is responsible for residency training, and we're responsible for accrediting and determining who becomes a consultant. But in the region, there are two colleges. There's the West African College of Physicians and the West African College of Surgeons. And in Nigeria, we were happy because we sort of had our own way, but we were having a lot of pleas from people all over the region, in Togo, in Benin, in Liberia, asking for pathways to emergency medicine residency and training, and there was nothing for them. I think the colleges are very competitive, and I think West Africa finally realized that they were being left behind and have agreed now to certify and accredit emergency medicine as a specialty by the end of the year, which is a huge one for us because they were going down another path that was very crazy. They were doing something about acute care medicine. You had to do internal medicine first and then become an EP. It was very messy, but I think they've realized now that emergency medicine is its own thing, and that's going to come in by the end of the year, which means that the 16 countries in the West Africa sub-region will now have a pathway to residency training and specialization in West Africa, which is something that we really need. And of course, they're trying to harmonize the curriculum so that we're not too far off. Residency training updates, this is our first class. As I said, they're about to be done in 2 years. The residency director at UCH Ibadan was actually Kendo Jifini and then Rotimi Akinola. They're essay-trained EPs. All 4 of us who are residency trained are all diaspora trained. There are no Nigerian trained EPs in Nigeria at the moment. And then at Cedar Crest, the director of that program trained in the UK and is also leading that out. And we're really proud of these guys. They're really doing amazing work. I think we've kind of talked about most of this already. We've described what we're doing in the African Journal of Emergency Medicine and just sort of explained our process. For us, I think the main key to getting some traction on this was the recognition by the college. Every conversation before that was us speculating. Once the federal government of Nigeria said emergency medicine is a specialty, we came from a very different place when we started to have conversations with allied specialists. And I think for me, when I'm advising people about setting this up, it's important to do the advocacy and start the training and the work. But if you don't have that backing from whatever organization gives you specialty recognition, it's all just in your cupboard. There's nothing happening that's really going to drive this forward. So we have our association, as we said, over here now. All our residents are joining it, and we've had amazing support from EM RAP, from EB Medicine, a lot of emergency medicine sort of resources and FOAM and all the organizations really trying to help us grow. I'm appealing to all of you because, as I said, we're very stretched. Any kind of support, collaboration around building emergency medicine in Nigeria is very welcome because we realize that we do need a lot of expertise and support. And here's my hospital, Our Jalad. As I said, we're one of the busiest private teaching hospitals in the country. We had, this is now even old data, we're seeing about 250,000 patients a year. Our ER is very small, it's doubling or tripling in size at this point, and our acuity has been growing as the ICU opens up. So we're really proud of our medical officers there who are really taking up the challenge of treating these emergencies as they come in. Every time you go to an ER in Nigeria, 9 times out of 10, the person treating you is the youngest doctor in the room, fresh out of medical school with no prior training in emergency care, and they're usually left alone. And so we are very unique in that there's only 2 or 3 places where you go in and actually see a department led by an EP who's actually had some training. And we're seeing that in our outcomes and in how we're treating our patients. So, and then, of course, our research portfolio is growing. We're doing quite a lot of work in sepsis. We're about to do stuff in stroke. This, for me, is actually the thing that is the crown jewel. We have to, 4 minutes, we have to find a way to begin to develop our own clinical scores, guidelines, and prognostication information. Nigeria is a mishmash. People come back home from the UK, from the US, from Australia. So everybody is practicing in different ways. And none of us have a way to do this in Nigeria with our own epidemiology and our own patients and our own type of presentations, which are very different from what you see in the West. And so this work is needed because even simple questions like, doctor, I had a stroke, what does this mean for me, are very hard to explain for us because we don't have any data on our population. A lot of emergency medicine data in Africa tends to come from East Africa or South Africa, and we're very different populations. And so we're trying to begin to sort of do this work so that we have information about what's going on. Here is emergency medicine consultants. We've been training now about 7 years, over 1,000 people, bringing point of care ultrasound and also emergency and critical care training locally to Nigerians. And there's our impact. And I think I've spoken about some of our current challenges. And so we're still on the journey, but we're really proud of what we're doing. Emergency medicine is growing, and we know that we are going to get there eventually and scale this summit. Thank you.
Thank you very much, Dr. Fasina-Ayoola. I think we can take one question to the maximum because we have 2 minutes. Yes, please pass the mic. Dr. Fasina, please take the mic.
Dr. Fasina, first of all, I'm Diego from Canada. I'd like to congratulate you for moving from USA to Nigeria and be a pioneer of EP in Nigeria. It's not always easy. I have only one question. How do you retain your staff after training 75 ED doctors?
I think that the reality of it now in places like Nigeria is that we have no way of retaining the people we train. Even on interviews now, when we ask them, you have to be very blunt because even as you're interviewing for a role, they are explaining to you that they have only a year or two left in country, exit strategy, PLABs are being done, USMLEs are being done, they're on their way out. That was something that was inhibiting to people in the past, but I think we've just gotten to the point now where we're just trying to organize ourselves really well so that we are consistent. There is churn in our system. It causes a lot of issues because we don't have a lot of senior expertise around. But what you have to do is have systems, protocols, and guidelines where people are constantly trained and you don't allow things to fall through the cracks because the system is there. And that is the hard work. But the reality of it is that you cannot keep people anymore. They are on their way even as they are applying for the jobs. They don't intend to stay.
Thank you, Dr. Fasina-Ayoola. That's very eye-opening. And we have moved from Europe to Africa. And now we're going to go to South Asia. We all share the same problems despite our economic status. It is interesting to hear this. I would like to invite our next speaker, Dr. Nilanka Mudithakumara. She's an associate specialist emergency physician with pending her final year overseas training from Sri Lanka. She has other postgraduate qualifications in sports medicine, medical physiology. She is the winner of South Asia Young Faculty Presentation organized by South Asian Collaboration for Emergency Medicine in 2023. She has special interest in innovative teaching, AI in EM, quality improvement of patient care, organizing events, gender justice, and volunteering. She's program lead of IFEM Early Career Special Interest Group and been the voice of global emergency trainees representing LMIC and female trainees across the renowned world EM platforms. So over to you, Dr. Nilanka, and another fellow colleague from Sri Lanka. I'm honored to introduce you today.
Thank you very much. Yeah, it's so happy and a special occasion to be sharing as the chair and the speaker, being the same country, same colleagues, and my senior. Thank you very much. So it's about researching the research interest, and it's about being a trainee up until now for 4 years and pending 1 year more. How I saw the problems of the research amongst the trainees. And it was about how different countries face these problems in research, which difficulties we have, how we can overcome those, and what different countries and how different countries has approached this. So we share a common destination. It's our motherland, Sri Lanka. This is my outline. Let's talk about the global paradox of research interest and the differences between low middle income countries and high middle income countries, and the global spotlights and special initiatives, and about our own country, and the execution gap and the skills defect, and introducing the global toolkit. EM research, it equals to patient care. Does it really do? Yes, it does. We don't think most of the time. We don't have time to do research. We don't spend special time to dig into research and find the evidence. All of us are busy with doing research. No, we are not busy with doing research. We are busy with the clinicals. We are busy with the training. We are busy with the assignments and everything. And we forget that the research contributes to the evidence-based practice, which in turn will do the system optimization and professional survival. This is all about trainees research. It's a pulse, it's the heart, it's the evidence. Of course, this is a limited evidence topic and an academic blind spot. It is highly underdocumented. It's very difficult to find any evidence what these residents are thinking of research. It's especially a blind spot in emergency medicine new countries, which has developing emergency medicine as well. So we think the high income countries have mandated protected time, institutional grants, and the resources and literature access, and large faculty mentoring pools. In contrast, low middle income countries, including ours, we have a burden of overwhelming clinical volume, and we have to depend on our self-funding and lack of access and resources. And we don't have access to well-known, renowned resources and literature. And there's a lack of local mentorship as well. Well, I got an opportunity to do a survey amongst our international fraternity, talk to them, and collect evidence. What do they really think? Depending on a previous survey done in Sri Lanka, I expanded it into global scale as well. But at the end, the differences may be not what we think. Of course, there's a burden versus output imbalance. If you see the low middle income countries, we have the global disease burden of 90%. But the trial output is very limited. It should have been the otherwise, isn't it? So we can provide to the database more. And the literature paywall. It's very difficult to get access to newly published and well-quality peer-reviewed literature because we have to pay for them and we can't afford from our countries. And the funding, it's a nightmare. It's not a reality. Small cost, the printing, logistics, all are borne from our pockets. And the statistics softwares, no one is going to supply those. And the article processing charges. If you just compare with the low-income countries and low-middle-income countries, I think low-income countries still have some more funding than ours. Especially in APCs, they have full waiver, where we have only 50%. That 50% is also a huge burden for us. And the mentorship wide. we have limited confident and qualified emergency physicians. So it's very hard to find a suitable clinical administration when we have an acute patient load to manage with. Well, these are some examples from different countries. AI-driven research and big data access, for example, in Taiwan. If you take Philippines, there are residency training competitions and a lot of appreciation and encouragement. I've seen even in the ICEM or SM or whatever, how they congratulate and appreciate their trainees. It's really commendable. And there are some dedicated resident collaboration, for example, in Saudi Arabia, promoting and guaranteeing mentorship and opportunities for the presentation. And Africa. Well, there are voices from Africa. There are limitations, there are challenges, but this Delta initiative has supported a lot for the African trainees as well. Turning back to Sri Lanka, this has been a glimpse of what we have audited amongst our trainees. The areas assessed were research involvement, presentation and publication, and research courses attended, basic research knowledge, specific research interest, perceived areas needing support, and challenges and expectations. What we have found is there has been a difficulty in initiating the research, despite we were having a mandatory training program of research, 5 days training program for the trainees. There's a gap, of course, in between the interest and implication. We have done something practical, maybe twice, but last year during our academic conference, with the input of attempts to increase the interest, initial submission of 12 abstracts has been increased to 95. That shows the clinical interest for research. Our trainees are interested in publishing the case reports, but they need more support to go beyond. I think Sri Lanka is turning towards a better future. So many initiatives are being carried out at the moment. So we are looking forwards for more phases in the upcoming ICEM as well. Well, these are the problems we have found: initiating paralysis, core skill deficits, and study design hurdles, which we'll be responding soon as well. And the 90s Club of Deficits. There are so many deficiencies. Those who haven't done any research before, that almost more than 90%. And those who haven't done any journal publication, same. And the conference presentations. Well, now we have given the platform after a period of crisis, COVID, and all the instabilities starting from last year for them to publish. And I think now the trend is going on, but we should let the doors get open for the international platform as well. And how to do a primary research. This should be an initiative. So we can provide more to the database, more evidence-based, more strong evidence to who need. For example, at the moment, I work in one of the busiest emergency departments in the country, Colombo South Teaching Hospital. We have 88 beds and we get about 350 patients or more per day. So it's a huge resource stock. We can get a lot of evidence, lot of research, lot of support to the low middle income country evidence base if we do some research, if we get some research. Still there are some barriers. For example, the ethical clearance and whom to go next, what to do next. There should be some guidance. They say always the first step is the most difficult. So we should collaborate or we should help our juniors, our residents, to keep that first step. If they keep that first step, they will keep on walking. So our expectations include there should be some dedicated mentorship and access to the reference material and protected time for research, because we have an overwhelming patient load and a tight schedule with the training. Let it be during our conference time or like that, there should be some training program and maybe a small but helpful research funding, because the training period, of course, is additional expenditure to the pocket. So if the trainees get some help during that period, it would be beneficial for them as well. And the positive feedback, it would do a lot than the negative feedback. Let them take the first step and let us cheer from the background so they will keep on walking. These are our thoughts to build the EM research culture in a low middle income country as ours. So, going to the proposed global toolkit, mentorship matching. So for example, ICEM is a good platform to initiate the research. And it's very warm and welcoming for the juniors as me. I have entered ICEM or IFEM 4 years back when I was just a first year resident. They have held my hand and brought me up until here. So I think if I could come here, anyone or everyone else could, with all these blessings and all this support. And the protected time. We can think of institutional mandates, or like they can give some period. Within this period, you can do this research, and the guided mentorship and protected library and the stats resources and some helping hand to do what is most difficult. For example, sample size calculation or the statistics part, which we emergency physicians are not very fond of or not very competent of. And I like innovative teaching. I think we can use something innovative to refine or simplify these statistics as well. And for example, to my left, our Madam Chair also has been a grantee of the ICEM grants. So I think still it's possible to our low-middle income countries. There are sources, but not very much. If you strive, where there's a will, there's a way. So it's not one step at once, but it's a pathway, it's a roadmap. I think the seed of interest in research should be implanted from the first year onwards. So it will keep on growing. So for example, in Sri Lanka, it's a 5-year residency course. So by the end of the 5 years, when a confident emergency physician comes out as a consultant, he or she will of course think not only the clinical aspect, but the responsibility of rewarding and contributing to the database and our own population as well. Because there is always a question, can we apply the Western data or Western guidelines or high middle income country data and the guidelines to our setup? The answer is we don't know, because we don't have any evidence. So my wish is a bright future. Let the trainees think, let the trainees get engaged with research. Let there be a paper telling that the increased research interest has happened in the trainees of emergency medicine as well. Thank you very much.
Thank you, Nilanka, for explaining what a luxury it is to do research in LMIC as a trainee. I would like to throw the mic. Anyone who would like to ask a question? Okay, let me ask a question. What is the 90s club deficit, which I don't know?
Let me go back to you. It's just a common term. If you see, there are like so many areas, the deficiencies and like over above in our audit. So that's just a name I have used. There are so many, those who haven't done any journal publications, and so many who hasn't initiated the primary research, and so many who have the interest and not started any report writing or don't have any area of topic researching, and they don't have any idea what to do and difficulties in initiating. So that's like the example to say the majority don't have that qualification.
So thank you very much, Nilanka, for your ideas, thoughts, and explaining the expectations of the trainees. Since this is on social media, I think there's a wider audience out there who would appreciate and share these same issues and benefit from the suggestions that you have made today. That concludes today's session on advocacy in EM. Thank you very much for joining with us in this platform through social media as well as live. Thank you.
Thank you.